Hi, good day to all of you. Today we are going to see another topic in the management of ischemic heart disease. We are going to see about the management of ST elevation MI. So first, when a patient comes to us with an acute coronary syndrome, be it an unstable angina, non-ST elevation MI or an ST elevation MI, we will have to risk categorize them. As to what does this risk categorization help us to do? So when a patient comes to us, you would have all heard about coronary angiogram, coronary artery bypass grafting. Who needs these procedures immediately? For whom can there be a delay in doing an angiogram or a CABG? So to decide whether an invasive strategy is needed or a medical management is needed initially when a patient comes to us, and how yearly this invasive management is needed, whether an yearly invasive management is necessary in a patient or we can wait for this invasive management. To decide that, we will have to risk categorize the patient. Certain scores are used like the STIMI score and the GRACE score that we will be seeing in the upcoming slide to do this risk categorization. So what are the components of the TIMI score? You will see certain epidemiological factors like age of the patient will be taken, and certain factors which are specific to the patient like a past history, a risk factor for ACS which is already there in the patient or we have diagnosed it at the time of admission to the hospital, be it hypertension, diabetes, dyslipidemia, a history of smoking or a family history of acute coronary syndrome, especially if it is in a younger age. So patient has a sibling who had an younger age MI, then such a patient will constitute this risk factor for acute coronary syndrome. So someone who is having more than or equal to 3 risk factors, use of aspirin in the last 7 days, prior coronary stenosis, patient who has already had a previous episode of an acute coronary syndrome which was diagnosed as an acute coronary syndrome, or routine evaluation showed that some indication for a coronary angiogram was there, which showed a coronary stenosis which is more than or equal to 50% in the angiogram. So more than or equal to 2 angina events in the past 24 hours, or patient is having persisting discomfort when he presents to the hospital. ECG is showing an ST elevation, which means, or an ST depression, which means it is an acute coronary syndrome which has happened now. On the initial ECG, patient presents to you, you take an ECG, you see an ST elevation or a non-ST elevation MI. So an ST segment deviation, not a T inversion, an ST segment deviation is important. Elevated cardiac biomarkers, what is it going to tell you? That it is either a non-ST elevation MI or it is an ST elevation MI. Only in these two types of acute coronary syndromes, you will have an elevated cardiac biomarker. So all these are taken into account. For each we give 1 point, and the total points will categorize the patient into 3 groups, either a low risk, intermediate risk or high risk. What do we have to remember in this? Mainly, remember that there is a score called a TIMI score. Certain factors like age, risk factors, previous history of aspirin usage, coronary stenosis, at the time of presentation, the clinical feature of the patient, the ECG of the patient, whether there is an elevated cardiac biomarker or not. All these play a role in determining the risk of the patient. Next score that we will see is a GRACE score. So in this GRACE score, this is the one that we give a lot of importance to nowadays. So we take certain factors, just like in the previous score, we take age into account, and clinical examination wise, what and all points do we take here? Heart rate, BP. So vitals are taken into account. Lab investigation wise, we take the creatinine value into account, and on auscultation, we will be discussing about the KILIP class in the upcoming slides. This is a clinical examination guided classification of patients based on their risk for progressive morbidity in case of ST elevation MI. So on clinical examination, mainly on auscultation and looking for certain other clinical signs which we have discussed about in the class on acute coronary syndrome, the initial class. So all these factors will be taken into account in the KILIP class, and this clinical classification is done into 1, 2, 3 and 4. This will be taken into account under the GRACE score. A history of cardiac arrest at the time of presentation. Many times patients come to the hospital in a state of cardiac arrest. ECG, when we revive the patient, we take an ECG at the time of presentation, it shows an ST elevation MI. Or patient can develop a ventricular fibrillation, and once we defibrillate the patient and revert them to normal sinus rhythm, we notice that there is an MI which is there, which led to the ventricular fibrillation or ventricular tachycardia. That would have led to the cardiac arrest. So this cardiac arrest history in a patient, or patient having elevated cardiac biomarkers. So this is what we saw in the TIMI score also. Cardiac biomarker elevation, ST segment deviation. This is again something from the TIMI score. So you will notice points like age, the history of elevated cardiac biomarkers, ST segment deviation. These are all common to the TIMI score and GRACE score. So each value is given a particular point, and all these points are together added up, and again we risk categorize the patient into low risk, intermediate risk and high risk. So 2 scoring systems, TIMI score and GRACE score, are used to risk categorize to decide whether an early invasive management is necessary in a patient or not.